do my best to answer them at that time. Let's see if I can get my slides to go here. There we go. And so I'm always uncertain if I'm supposed to put up my disclosures, but I do a lot of diagnostic research, a lot of times involving cardiac markers. So we are partnering with several of the diagnostic companies in regards to that. So I am going to be talking about stress testing, but I'm going to really focus a little bit on the new protocol we have, put that in the context of risk stratification with mostly the heart score, but there are other risk stratification strategies out there too. And then we'll talk about how we see stress testing fitting into our protocol and what is the evidence for using CTA in this patient population, because I think that CTA in chest pain of uncertain etiology in the emergency department and the observation unit is something that is certainly underutilized in the Henry Ford Health System. And we probably should be doing more of that. And within the context of the new algorithm, we do hope to be growing that. So in every sort of presentation that I'm involved in, I like to start with, what is the question? What are we trying to answer? So the first question is the patient having an ACS? And then if once we are, kind of gone through that, it's not clear if it's an ACS or not, what is the most appropriate strategy to risk stratify those patients who can go home from the ED without even a stress test or CTA, and then who is in that risk profile that probably would need further testing, either a stress test or possibly a CTA. So kind of just to give you the outline of what I'm going to be talking about, a little bit about the background, observation units, how we kind of got to where we are, talk a little bit about what are classic symptoms that steer us towards ACS, away from ACS, a little bit about the cardiac markers, the high sensitivity troponins and how we can utilize them, stress testing and CTA, risk scores, and then once again, I'll put that in the context of the new Henry Ford algorithm, which we've had here at the downtown campus for several weeks. So what is sort of the historical context for this? So this is now a very old article published really 20 years ago, but it is this study and some other ones, but this one is probably the most cited one that got everybody's attention. Is the misdiagnosis of acute cardiac ischemia, either MI or unstable angina, in the emergency department, published in 2000. Very large study. This was all in the US, over 10,000 patients, 10 US hospitals back in 1993, and they looked at anybody who came in with any sort of pain that possibly could be ACS. If you came with chest pain, arm pain, jaw pain, upper abdominal pain, shortness of breath, all those patients were put into the study, and everyone returned in 24 to 72 hours for an EKG and a CKMB, if any remembers that. And those are the markers we used to use in the past, back 20 years ago. Those cases were reviewed by cardiologists and decided if indeed it was a missed ACS or not. And the results of that study showed that the missed diagnosis was about 2%. So 2% of MIs were missed, inadvertently sent home. Unstable angina, a little bit more, 2.3% missed and went home. This trial didn't cite that, but there's other trials that cited, well, no big surprise, if you have a missed ACS and go home, your 30-day outcome is much worse and a much higher mortality rate than if you were admitted to the hospital, obviously, and treated. And then these were the factors in that study that were associated with missed ACS. So if you do not have any chest pain at all, just presented with shortness of breath, if you are a younger woman, less than 55, if you were non-white or had a normal EKG, those are all the independent predictors of missed ACS. So you might say, well, missed ACS, 98%, we identify 98%, you only missed 2%. I mean, that's a very small number, but 2% of a very big number ends up being a pretty big number. So we have about 8 to 13 million people evaluated each year in the United States for possible ACS. That's an old number. It's probably actually bigger. About 20% have ACS. Maybe it's 15%, but it's around in that. If we assume 2% are missed, that comes out doing the math, to 32,000 to 52,000 missed ACS per year in the United States. So that's a pretty big number. And then if you put it in the context of the United States of the medical legal issues, here's some data on that. So this is always something that gets cited, and we're always concerned about the medical legal aspect. And we shouldn't practice just based on medical legal aspects, but it is certainly the environment we work in. 25% of all money paid in malpractice claims relates to missed ACS in the United States. And then if you look at what are the subspecialties or medical disciplines, the ones that actually get malpractice claims for missed ACS, this is the different groups that are actually have successful malpractice claims against them. Emergency medicine really is a minority of that. It's less than 20% is emergency medicine for missed ACS. Cardiology, missed ACS is less than 5%. It's not that we're that much smarter in cardiology or smarter at all. It's that cardiology rarely sees these patients up front. They're almost always triaged through somebody else. And the most successful malpractice claims are actually in the outpatient setting, internal medicine, family practice. So this data really has certainly got the attention in the United States. And so that sort of led to some of the broad guidelines that we have operational in the US. So this is an AHA ACC guideline from Circulation 2014. I'll let you know that this guideline is being updated right now, but it still has not been published. And basically the verbiage here is that it is reasonable to do stress testing in patients when the diagnosis is unclear and the EKG and the troponins don't definitely steer you towards one diagnosis, stress testing, or even CTA. And then this really led to becoming the standard of care in the United States, that if they have uncertain diagnosis, you don't know what's going on, you should do a stress test. And that actually has led to literally millions of tests, and there's certainly a lot of cost for that. And the problem, and I'll show you some data on this, is that such a broad application of this to even some very low risk patients leads to a lot of false positive tests. But this is the environment we have been practicing in. So what are the costs for this? The estimations are that there's $10 to $12 billion spent in the United States to evaluate patients just in the ED with possible ACS. So it's a very costly endeavor too. And just to quickly kind of go over symptoms, because even in the risk scores that we apply, symptoms are very important in trying to determine what's your pretest probability. So if you look at a multitude of publications, these are basically the symptoms that suggest possible acute coronary syndrome. So if you have diaphoresis, radiation to the arms, pressure in the chest, with exertion, nausea, or similar to prior MI or angina, those have been published as independent predictors of ACS, MI, or unstable angina. And these are symptoms that have shown to be non-predictive of MI. So if you had these kind of symptoms, it steers you away independently from an MI diagnosis or ACS diagnosis. So pleuritic chest pain, positional, sharp, reproducible, not associated with exertion. So that kind of helps us sort out atypical from atypical symptoms. And so I'm putting this up because this is a more contemporary study in the troponin era. A lot of those studies that I showed you those symptoms for are from studies that are decades old using CKMB. But this was a multi-center trial published in 2016 in the US, Europe, and Australia. And this was actually using a high sensitivity troponin assay. And the symptoms were looked at in this study, the so-called TRAPID MI study. And this trial had a little more than 1,000 patients, 1,282, 12 centers, and 17% of these patients were diagnosed with MI. And out of this data set, there were only 4 independent predictors of MI. Pressure in the chest, related to physical activity, radiation to left arm or left shoulder, or right arm or right shoulder. So these are ones that have been shown in the older studies, but these other symptoms that were shown in the older studies did not pan out to be independently predictive. Interesting enough, there were no symptoms in this data set that were independently predicted of not MI. So if you take a multitude of those symptoms, so if you have 1, 2, 3, or 4 of them, obviously if they're independent predictors, the more of them that you have, the more likely the diagnosis is going to be MI. So in those patients that had all 4 of those symptoms, more than half of them ultimately were diagnosed with MI. Not perfect, but those are the symptoms that kind of help steer you one way or another. In regards to EKG, the other tool that we use tremendously in evaluating these patients, the first thing we try to evaluate for is STEMI. Most patients don't have STEMI. But if you look at NSTEMI patients, there's really only diagnostic EKG findings in about 20 to 30% of the cases. That number is probably an overstatement because a lot of those studies were based on old definition of MI using CKMB. So I would say that some of the smaller MIs we're identifying now with troponins, the numbers that have diagnostic EKG changes are probably less. And you can have an absolutely normal EKG and have an MI. 6 to 10% of MIs will have an absolutely normal EKG. So a little bit about stress testing. And so what I'm going to try to emphasize in this talk is the role of stress testing and how we might think of it differently now in the context of the new algorithm that we are using at the downtown campus. So we're going to kind of go over a little bit about some of the studies that have looked at stress testing in CTA. And just sort of as a background, there really has been a paucity of randomized trials looking at different strategies for chest pain in the emergency department setting. So I'm going to go over some of the CTA trials, but prior to the CTA trials, there were really only 2 studies that looked at different strategies in some randomized fashion. One was looking at exercise EKG, and the other one was looking at rest MPI. And these are very old studies. And also note, one of the challenges in these kind of studies is you need a large number of patients to power the trial for outcomes. And so really the outcomes in these studies, and I'll show you really most of the other studies, the primary endpoints that have been studied have been resource utilization, admission, costs, and time spent in the emergency department. A little quick word about regular stress testing. We rarely use it. However, there are studies out there that show that if you're able to exercise and you have a normal EKG to begin with, a regular treadmill can be quite reasonable approach when you're trying to risk stratify what's going on with the patient. So this is a very old trial. 1,000 patients, ability to exercise. You have to have a fairly normal EKG, hemodynamically stable, no arrhythmias. And in that study, if you had a negative stress test, 640 had a negative stress test, there was only 1 adverse event at 30 days, 1 NSTEMI, and there were no deaths. So the negative predictive value was very high at 99.8. We tend not to use this as much because sometimes they have shortness of breath, they may have a heart murmur, we're interested in LV function. But personally, if I have a patient I'm seeing in the observation unit and I'm getting some questions about this, I might recommend a regular stress test just for prognostication to get them through the system a little faster and then give them outpatient follow-up. So, just to sort of summarize on regular stress testing, a normal standard stress test at an adequate workload has high prognostic utility. It is not so sensitive for identifying CAD. You can miss single vessel CAD on a regular stress test. Sensitivities for regular treadmills have been identified any place between 50 and 70%. But in the ED setting or the observation setting, the main question is not the presence of CAD, but you're really worried about the risk of a short-term adverse cardiac event. What's going to happen to them in 30 days? So if you can run on a treadmill, go 12 minutes, have no pain, normal hemodynamic response, you can be comfortable that patient can go home and have any further workup as an outpatient. So a little bit about the CT trials. There have been now at least two, or rather three large randomized trials looking at CT in the emergency department, and there's several other trials looking at it in the outpatient setting. But I picked these three because these are the three that are probably the most cited and have impact some of the guidelines. So there's the CT STAT, which came out in 2011, the ACRIN 2012, and then the RomiCat study that came also out in 2012. I'm going to tell you a few criticism I have of these studies, but I think they really did a great service to us to sort of lead the way on how these kind of trials should be done. So a little bit about the first one. This was the one published in JACC in 2011. And basically, this is sort of a busy slide from that trial. And they were kind of comparing the CT A wing to standard of care. The standard of care in this trial was really doing mostly nuclear stress testing. And I just want to show you for the study purposes. And can you guys see my mouse? Can you see my pointer?
No.
Okay, all right. So so if you look at the top here, there's over 6,000 patients who were screened for the study. If you follow down, of the screening, only 749 were able to be enrolled. So you have to understand with the CT, there's issues with that. So in other words, if they're tachycardic, they have arrhythmias, they have kidney issues, they have dye allergies. There are a decent number of patients that are really not candidates for CTAs, although that has been improving with better technology. And then if you look at the outcomes of this trial, this trial was powered to look at resource utilization. So time to diagnosis and total ED costs. So if you look over to the CTA column here and the MPI group, the time to diagnosis was 2.9 hours in the CTS, in the CT wing. It was over 6 hours in the MPI. The total ED costs, partially driven by a shorter length of stay, was more expensive if they were in the MPI wing. So this is not so surprising. Most institutions in this study were able to do CTs more readily than they were able to do MPIs. But bottom line was, in these particular hospitals, they could get access to CTAs faster, and there was an ED cost savings there. If you look at one of the other trials, the ACRIN trial, there was a higher revascularization rate if you got randomized to the CT wing. So if you had a CT, 3% of them end up getting revascularization. If you went to standard of care, only 1%. Now, once again, these look like very small numbers, but these are small numbers of millions of patients. So you are tripling the revascularization if you go with the CTA route. And you have to wonder that if these patients come with some atypical chest pain, they rule out, you find a lesion by the CTA to get to cath and get an angioplasty, you really wonder how many of those patients actually had outcomes that were improved. We have no follow-up in regards to were their symptoms better, and there's certainly no data to suggest that revascularizing this patient population actually improves patient outcomes. And then looking at the RomiCat trial, if you compare, go to the right, the last two columns there, if you got randomized to the CT wing, you were much more likely to get 2 or more tests as opposed to the stress test. So 27% of the patients who went to get a CTA had 2 or more tests, while those only 12% if you went the standard pathway. And probably what happened, or actually what did happen, was in that article, they showed that if you had a CTA, it was not diagnostic, or maybe you had some intermediate lesions, some went on to get a nuclear stress test, and then based on that, someone would get a cath. So sometimes people would get a CT, a nuclear stress test, and a cath. And then if you go down at the bottom there in those two columns, which highlighted in red, circled by red, if you're randomized to CT, your millisieverts, radiation exposure, was much higher than if you got evaluated by standard. It was almost 3 times as much radiation exposure if you got randomized to CT. And I showed you some data earlier that if you got the CT, it was cheaper from the ED perspective, but in the Romacat trial, they looked at 30-day cost, and the cost was actually higher at 30 days, driven by additional testing than if actually you went with a regular stress test. So the data for even it being cost effective is not very good in the randomized trials. And this is just a graph kind of showing you, I think something you know, we do have a lot more CT utilization in the United States. And this is not inconsequential. I'm not showing you data on this, but there is some estimations that 2% of all cancers in the United States are actually caused by medical radiation. So once again, 2% of a very big number ends up being thousands of patients each year. So I'm not saying we should not do tests that give you radiation exposure, but we probably should be limiting that and certainly not doing patients that are very low risk. So that is some sort of the negative aspect of CTAs, but there have been more contemporary look at some of these trials and putting together in a meta-analysis, and this was published in 2017, comparing CTA versus stress testing. And one of the criticisms I gave you before was there's really not been any good data to suggest that a CTA approach improves outcomes. However, this meta-analysis actually sheds a little light on that maybe CTA can actually improve outcomes. So it's a little hard to see this, but this is just showing you, these are multiple studies looking at CT versus some standard of care evaluation, some functional testing, some stress nuclear, some stress echoes, some regular stress testing intermingled there. And they did this meta-analysis and looked at some hard outcomes. So once again, this is a busy slide, but if you go all the way down to the bottom there was a statistically significant decrease in MACE rate in patients that get randomized towards CT in the meta-analysis. Now you have to take this with a grain of salt. There's some criticism you can give with meta-analysis, but this is the data. And then if you look at what adverse events were improved, it was basically a decrease in MI rate. And so what appears to be happening is if you get randomized to CT, we identify more atherosclerosis. You may identify patients with mild or moderate lesions, things that you would not be finding on functional testing. And if you do find that, those patients get treated differently. So if you look at number one here, if you get randomized to CT, you're more likely to get a statin than if you get a stress test. You're more likely to get an aspirin. And then your MI rate was driven down from 1.1% to 0.7%. Once again, those are small numbers, but it was statistically significant, and it is a decrease of only an absolute decrease of 0.4%. But once again, that's limiting the number of MIs by thousands because you're looking at a big number of patients each year. So this kind of data has led to some international guidelines to be changed. So this is guidelines out of England. The so-called NICE guidelines is from the National Institute of Health in England, and they recommend now, if you don't have any history of CAD and you have chest pain of uncertain etiology, they recommend at the national level to go to a CT first and not a stress test. So a little bit of concerns once again about the CT approach though. You do get a radiation dose. There is a cumulative cancer risk from doing that. However, the newer scanners really have decreased that quite a bit. So that is not as of concern as it had been in the past. CTA, you do tend to get more revascularization. Does that lead to increased better outcomes? We're not sure. But it does appear that you do identify atherosclerosis, and those patients do tend to get treated for secondary prevention, or I should say rather primary prevention with statins and aspirin. So I think there is some justification now to be using CTA a lot more in the observation setting. So a little bit about risk scores, because the risk scores are integrated into our risk stratification strategies. So there's been multiple risk scores. There's probably at least 10 that have been published on. TIMI score is a common score that has been mostly validated in the definite ACS population. The two other scores that have probably been the most published on are the HEART score and the EDAC score. EDAC score may be considered the most scientifically valid, but the most cumbersome score to use, and really has only been studied well in the Australian population where this score was generated. And I think the HEART score is probably the one most used and more commonly used in the emergency department in the United States. Part of that is because it's easy to use, and actually there have been a decent number of validation studies for the HEART score. So this is actually some data from Henry Ford here. We did look at the TIMI score on patients that come through the emergency department with chest pain, unclear etiology, excluding STEMI patients. And if you look at the TIMI score, it's really only 4 of the aspects of the TIMI score that were predictive of adverse events. No big surprise, elevated troponin, EKG changing. If you have a known history of CAD, by catheterization, if you're older, those were independent predictors of adverse events. Now, a little bit about the HEART score. I was raised Roman Catholic. I don't know if there's any Catholics out there on the talk here, but I sort of naturally gravitate towards things that divide entities into 3, and that is exactly what the HEART score does. So this is a copy of the classic HEART score. So it's an acronym. H is the history, E is the EKG, A for age, R for risk factors. And in the original classical HEART score, troponin was integrated in that part of the calculation. And of those 5 categories, they get subcategorized into high, moderate, or low risk. And they're assigned a number, 2, 1, or 0. And then you add those together to come up with an overall score. So your lowest potential score would be 0, and the highest score would be 10. And once again, this is the traditional HEART score with the troponin integrated in it, and that's not exactly how it's being used clinically. No, we're using it, but that was the original publications. And if you look at putting a lot of these studies together of the traditional HEART score, this is, I think it's like 8 or 9 different studies, over 20,000 patients, looking at the adverse event rate at 30 days, MI or death. If the HEART score was 3 or less, and that seemed to be the inflection point, your adverse event rate was anyplace from 0.6 to 3.6% in these studies. So 0.6 sounds pretty good. The sort of accepted missed rate when using risk scores is really less than 1%. But in some of the studies, it was high at 3.6%, which is really not good enough for an accepted missed rate. And once again, that's for using the traditional HEART score. And in comparing multiple studies, comparing the HEART score to this TIMI score, this is sort of the HEART score in purple. It kind of shows you that the HEART score outperforms the TIMI score, meaning that if your HEART score is low, you really don't start getting an adverse event rate until you get about 4 or above, and the TIMI score, on the other hand, increases rather quickly as you look at increasing numbers. And just to reiterate what I said before, the TIMI score really has been evaluated or validated in the ACS population and not so well studied or validated in the chest pain of uncertain etiology in the emergency department. And then this is referenced back to this other more contemporary trial, the so-called TRAPID trial, looking at HEART score. And that's in this study, once again, a multi-center trial, integrated the HEART score with the 0-1-hour algorithm, which I'm going to touch on in a few slides. That's the algorithm we're using now here at Henry Ford. And once again, in this study, over 1,200 patients, about 70% had an MI. If you looked at this study, the 1-hour delta algorithm actually missed 7 MIs, decent sensitivity. But if you applied the HEART score to this patient population, it helped in risk stratification. So what they looked at in here was looking at the HEART score added on to either just a number of the troponin over a period of time, those that are below the 99th percentile, or looked at the ones that ruled out by the 0-1 algorithm. So, and this was ended up being a separate publication, but looking at that data, if you look at the patients that had a negative troponin, less than the 99th percentile of presentation and a low heart score, and that's in this sort of first column towards the left in that sort of orange color, that's showing you low heart score, low troponin at the beginning, less than the 99th percentile, your adverse event rate was less than 1%. If you look at the blue column, if the heart score was higher, your adverse event rate was 6%. And then you can see that as you get serial troponins over time, the adverse event rate would go down. In other words, it kind of shows you that the heart score helps you early on, but if the heart score is high, then you get further risk stratification by measuring the serial troponins over a longer period of time. And then if you looked at the patients that ruled out by the 0-1 hour algorithm and applied the heart score to that, the adverse event rate at 30 days was for a low heart score, and you rule out was only 0.2%, while it was 2.3% if the heart score was 4 or above. So this is just some data to kind of help validate the heart score in regards into the era of high sensitivity troponin using that 0-1 algorithm. So basically from this study, they were able to show that almost 40% ruled out by the 1-hour algorithm and had a heart score less than or equal to 3. And so this sort of leads us to that, hey, maybe we shouldn't be doing stress testing or CTA in a lot of these patients. And just to share some internal data, this is application of the heart score even before we used high sensitivity troponin at some of our own patients in the observation unit. And this is data from back in 2013. And this, we looked at almost 800 patients that were in the observation unit with possible ACS. So unclear what the diagnosis was. So they ended up in observation unit. They all had 30-day follow-up. And all these patients underwent a stress test or CTA. And a total of 821 stress tests or CTA were done. So some of these patients, as happens sometimes, end up having more than one test. And we applied the heart score to that patient population. So about 30% of them had a heart score of 3 or less. And 92% of them actually had a normal stress test. And so they had a stress test and went home. Only 2% of that low heart score patient had a positive test. That's only 5 out of 238. And of those 5, 4 went to cath, and they all had normal cath or non-obstructive. Only 1 out of the 5 was an elderly patient. The cardiology consult team thought it was an atypical presentation and recommended medical management. So the false positive rate in those patients was actually any place from 80% to 100%, depending how you want to categorize that last patient that did not get a cath. So more evidence suggests that very low risk patients by the heart score probably do not need stress testing. And then a little more data from that, 6% had an indeterminate test, 2 had CTAs. We did a few CTAs back then. 1 was normal, 1 was diagnostic, non-diagnostic, but bottom line, for the low heart score, there were 0 deaths, 0 MIs, 0 revascularization procedures at 30 days. If the heart score was 4 or above, there was 1 MI at 30 days, there was 12 PCIs, and 2 bypass surgeries. So internal data, our own patients from our own observation unit from 7 years ago. And this is just another study looking at the rates of false positive tests in low risk patients in an observation unit, and they used a little bit different way of risk stratification in this study, but more evidence to suggest that if you have some strategy to put them in the low risk category and you stress them, the odds of you getting a false positive is high. So in this particular study, the false positive rate was 75% for MPIs and 67% for stress echoes. So how do we think now about stress testing on CTA in the context of our new algorithm? So just to reiterate a little bit about the high sensitivity troponin, We've had it for over a year now, but we've just only recently started using the high sensitivity component where we're actually reporting these very low levels from 4 to 18. 18 is the 99th percentile. And just to go to show you, this is a guideline from the European Society of Cardiology. If you look down at the bottom, this was published in 2015. And I'm just putting this up here to kind of show you this whole idea of a 0-1 algorithm has now made the guidelines even in Europe, because there have been a number of publications, and not only made the guidelines, but these are guidelines from over 5 years ago. There is not only a lot of studies on the 0-1 algorithm, there's a lot of studies to suggest that if you're very low at presentation, less than the level of detection, then your risk stratification is very good just from that one test, the so-called one and done. This is a publication from 2019, and basically showing that if your value was less than 2 for this particular assay, the sensitivity for MI was 100%. And then adverse events at 30 days, in those with a value less than 2, there was only 1 missed MI at 30 days. So the sensitivity for MI detection, 100%. The sensitivity for MACE prediction was 99.6%. If you study a large studies, this is never going to be 100%, but very good prognostication by that very low level. And in this multi-center trial, about 20% of them actually had that extremely low level. Now this is probably the largest trial to date looking at the high sensitivity troponin 0-1 hour algorithm and prognostication. This is the so-called COMPASS MI project. It was published in 2019 in New England. And what they did in here, they combined 15 international trials looking at high sensitivity troponin I and T, and this is over 20,000 patients, by far the largest study in this area. And what they kind of were able to show is that if the value was very low at presentation and not changing at 1 hour, the odds of having a MACE rate were very low. So this is sort of a cumbersome way of describing this, and my pointer, I guess I can't use the pointer, but focusing on this, basically if you look at the outer part of the circle, it says in this quarter section that the MI rate or death rate was less than 0.2% if your value was very low at presentation or not changing at 1 hour. And so what it kind of shows you is that for these different numbers, as you get a lower number, then you identify a little bit less patients. But the bottom line for this is that if you're low and not changing at 1 hour, your chance for an adverse event is very low at 30 days. So these findings have led to an updating of the guidelines in the European Society of Cardiology. So this is only from a few months ago, their guidelines from 2020. So not only have they said you can rule out MI, the prognostication is so strong for the 0-1 hour protocol is that if you rule out in this left wing here in the green, sort of in the green area, not only do you rule out, you should be discharged for outpatient follow-up and not have any stress testing or CTA. And just some data on why do we seem to identify such low-risk patients with these negative troponins. And this is a study out of Germany kind of looking at plaque by CTA and troponin elevation. So these are all outpatients. These are patients that have some risk factors, no chest pain, and they look at high sensitivity troponins and they look at plaque burden on the CTA. So 180 patients, 256 slice CTA, that's a very sensitive, and they looked at coronary calcifications, stenoses, non-calcified plaque, which is actually thought to be a riskier plaque, and then looked at vascular remodeling. This is where actually the plaque causes the vessel to sort of expand out. And we do know that when you have vascular remodeling with plaque formation, those are higher risk patients. So not to spend too much time on this, but if you go over to the far right, those with remodeled plaque tended to have chronic elevation in troponin. So what it does seem to be doing, it's not only ruling out MI, but if you have low levels, you're less likely to have plaque and less likely to actually to have high-risk vulnerable plaque. So that kind of leads us to our present algorithm, and we have three ways that we can rule out MI. You rule out by less than 4 presentation. If you equal 4 and your delta is less than 4 1 hour, you can rule out. And if you have a 5 or 6 or 7 presentation, then you have to get the 3-hour one. If they're all less than 18, then you rule out at the 3 hours. And then that leads to the protocol that the emergency department is presently using. And to break this down in more detail, this is just stating the ones that present with a very low level of presentation, less than 4. You rule out, nothing else going to the patient. That patient should go to home. No stress testing, no CTA, no going to the observation unit. They should actually go home from the ED. If they rule out by the second strategy, if they equal 4 but not changing more than 4 at 1 hour, once again, NSTEMI has been ruled out. They can go home, no testing, follow up with their PCP. Now, it's in this column that is one I would spend a little bit more time. So these are ones that are not above the 99th percentile, but they're not extremely low risk. These are the ones over 3 hours that have values between 5 and 18. And it is here where we think the HERE score or the heart score or modified heart score comes into play. So this is where we're actually looking at the 4 factors, the history, the EKG, the age, and the risk factors. And if they are low risk by that, equal 3 or less than 3, those patients we think also can go home. They could go home from the emergency department. They don't necessarily have to go to the observation unit. If the HERE score is greater than 3, 4 or above, those are the ones that should be considered for observation, should be considered for further testing. Which testing? Well, what we're trying to do is make CTA more available out of the observation unit. That's a work in progress. But if they don't have a history of CAD, we're going to try to make the option 1, the test preferred would be in that population, go to CTA. If, on the other hand, they have a history of CAD, prior angioplasty, bypass surgery, MI, then those are patients that we are going to consider more for stress testing. And then this is just a little bit more about patients with the higher values. The protocol really doesn't impact that because we still are going to be dealing with those as we've done in the past. If they're above 18, we have those numbers. We're looking for deltas. And if they're higher or they're changing dramatically, then we are more suspicious. If you look at the bottom of this, there is some good data that if their values are low, but changing at that 1 hour greater than 15, that's a high predictive value for having an MI. So for example, if their first value was 20 and a 1 hour value was 35, changing in 1 hour, the positive predictive value for an MI in that situation is about 80%, or 80% of those people will have an MI. So conclusions and leading a little bit of time for questions if there are any. High sensitivity troponin, very low, no delta at 1 hour, patients should be able to go home. If they don't rule out by the 0-1, but still have these low intermediate values, all less than 19, that's where we apply the heart score. Heart score less than or equal to 3, they should also go home. If they don't meet that criteria from the heart score, or to be more accurate, the HERE score, if they are 4 or above, then, and you think they need testing, then we are going to favor them getting CTA. We're working on, as I said, to make that more available. Presently, just so you know, we're applying the 0-1 algorithm in 2 of the emergency departments, Fairland and downtown. It's soon to be rolled out at Wyandotte. Hopefully what we're doing now won't have to be modified, but there will be a new publication coming out in 2021 with more recommended guidelines in the context of high sensitivity troponin about what kind of evaluation those patients should be having or not having. The 0 1 hour protocol, just to sort of make this clear, because this has led some confusion, should not be used on inpatients. This is really a protocol that's only been validated in the emergency department. And that is the end. I'm always on an email. If you have any questions you think of later, feel free to email me, and I'm willing and happy to take any questions if you have them now.
Thank you, Jim. That was a wonderful session. So folks on the call, please unmute yourself and post any questions if you have questions for Dr. McCord.
Yeah, this is Sri Pillai here. I have a question.
Okay.
So you mentioned if they don't have prior history of CAD, cabbage, going for a CTA,
Right.
if they have a history going for a traditional test like MPI, but what if they don't have a history of CAD, but there are EKG changes which are concerning, raising high probability for CAD? Would you still recommend a CTA?
Right. And so, we always have to, put this in clinical context. So if indeed you have some potentially dynamic EKG changes, history is bothersome, both of those or one of those, and your troponin is in that intermediate zone, then on those cases, you have to sort of make a judgment call. And that could be, further troponins to make sure they are not increasing if you have some dynamic changes in front of you. You may want to do just imaging in that situation where you might just get an echo to look for LV function. But interesting enough, the odds of having a bothersome ischemic EKG is astronomically low if they rule out by the 0 1. On the other hand, if they're in their intermediate zone and they have an ischemic EKG, that could be possible. Still unlikely if they're less than the 99th percentile. And in those cases, there's going to be judgment. I mean, I could see in certain cases, you're going to get different cardiologists recommending, different things. But if you have an ischemic looking EKG, decent story, then those are people you might have to be thinking about echo, consultation, or even admission if the EKG changes are dynamic.
Okay, thanks. And there's another second question, which I actually typed in chat. The question is, it's regarding one of the first slides you showed. You showed that the rate of missed MI was 2%, even though it's a small number, because it's the whole presentation is a big number, it's a big number. Did they mention why MI was missed? Was it history? Was it not doing EKG or troponin? Because that's an important piece of information I would like to know.
Yeah. Okay. So this is from the old an old study. So this is even prior to troponin. So this is when CKMB was being used, and so and these were the 4 independent predictors of missing the MI. So in other words, if they and it could be unstable angina too. They were short of breath. They were younger females. They were non-white or had a normal EKG at presentation. So what happens sometimes is they might just do one single marker at the beginning in some of them, and they didn't get serial markers because they thought the story was so weak. So those were the things that were the independent predictors.
Thanks a lot.
Yeah.
Thanks, Dr. McCord. I also have a quick question I typed in the
Sure.
chat. So in the slide, kind of in this area here, actually, these pieces of history that kind of raise your odds ratio for ACS. I've been looking for data to try to compare EKG changes, particularly trying to interpret, less specific findings such as T-wave inversions. How is it that you kind of frame, something that's a little bit less specific, like a T-wave inversion, when you're looking at an EKG?
So say again, I missed a little bit of that. What about the T-wave inversion?
So T-wave inversions in general are less specific EKG findings.
Yep.
And then when you're looking at that and faced with like a history that's somewhat indeterminate, is there data out there kind of looking at the odds ratio of T-wave inversions? I'm trying to frame.
Ooh, good question. So I don't know, to be honest, of publications to really some science looking at T-wave inversions. I know there we always say that they're not very specific, and they can be, you know, all sorts of T wave changes when there's CNS events, some electrolyte abnormalities. Without being able to cite a publication for you, I do know that we do get worried if you have the so-called Welland sign, the very deep T wave inversions in the anterior leads. But to be honest, I would have to, you know, look that up myself to find out any, you know, what the publications are for that. And then there's obviously, you know, tons of things if you really have ST depression or elevation, that those are generally predictors. But interesting enough, there are some studies that even if you have some ST elevation, if your troponin's negative, you know, a lot of those are early repolarizations or some chronic finding rather than an acute finding.
What about other kind of less specific EEG things like poor R wave progression? How does that kind of rate when we're looking at all of these findings?
That one I know a little bit about. It doesn't really help you so much, poor R wave progression. That's a very non-specific. I mean, if you have Q waves, that's different. But if you have just poor R wave progression, that can be a normal variant depending on how their heart is sitting in the chest, and even in sometimes how they put the leads on the patient. So not a very specific or helpful finding.
Got it. Well, thank you.
Yep.
Thanks, Jim. We have a couple more minutes. Could you talk to us about, as a cardiologist, what are you looking in the stress test, or what we should be looking on a stress test that will make us to call you for further consultation?
Right. Okay. So yeah, so I would say clearly I'll give you the two extremes where you definitely should be calling, and ones where you probably don't need to be calling. So if you got, you know, somebody that has some, you know, weird pain or even pretty good pain, but they go 15 minutes on a stress test, they have some EKG changes that normalizes quickly, and they have a small, you know, reversible defect, that is a very low risk patient that even if I thought they had angina, I would follow them up as an outpatient. So you know, very at a high level, no, you know, and once again, if that's someone who can actually walk on a treadmill. And then the ones we definitely want to get calls on are ones that, you know, have some ischemic changes early on, you know, EKG changing 1 or 2 minutes early on, drop in blood pressure, the whole anterior wall goes down, and then you have a lot of patients that you can't exercise and getting dobutamines, and getting pharmacologic MPI. You know, once again, it comes down to kind of how big the defect is. So if it's the whole ventricle that goes out, the whole anterior wall, then we definitely want to see them. If it's, you know, they've ruled out, now they have a mildly positive stress test, you know, small defect, you know, we're going to, for the most part, in those kind of patients, you know, recommend outpatient follow-up. Not surprising, you're going to get some different opinions on this when different cardiologists consult on those. But in general, that would be the approach, you know, that I would take.
Thanks, Jim. One more question from one of our hospitalists, Matt George from West Bloomfield. So he's asking, what do we do with a TID on an MPI read?
Okay, that's one. Yeah. Okay. Yeah. Well, that is a that I think that you know, can be trouble. So in other words, TID, we can see that transient ischemic dilatation on the nuclear test. That can be a technical issue with the test, that they didn't do it quite right, and it's nothing to worry about. However, it also can be a sign of balanced ischemia and 3-vessel disease. So it is a potential high-risk feature. So I would say if you see somebody then and they're calling TID, then I would say they're calling for a cardiology consult.
Okay, great. I think we're almost out of time. Any other questions?
I have a comment. Can I make a comment?
Yes,
sure.
go
Yeah.
ahead.
Yeah, so this is from an observation physician perspective.
Okay.
And as an observation physician, when I have a choice, I prefer to order a stress test rather than a CTA. One of the reasons being, if I order a CTA, I get at least 6 to 12 calls from the radiologist stating, hey, what is the heart rate? What is the heart rate? What IV access does the patient have? And there are times when I'm not on the floor or I'm busy with other patients. So if we can set up a protocol like ordering a CTA, it should come with a nursing communication stating, get a 18 gauge IV in the appropriate anticubital fossa. And I don't know whether it's possible to have a protocol for a beta blocker. Of course, the nurses can touch base with us to decide whether if they have concerns about the blood pressure, but that will actually make the workflow smoother and will kind of make us order more CTAs. That's the actual one of the actual issues I and many of my colleagues have with ordering a CTA. The 10 different calls we get from radiology.
Right. So yes, those are the practical issues we have with CTAs right now, and it needs to be easier. So you should be able to order it, and then the protocol get implemented, and it should just happen without having to get 2, 3, 4, or 5 calls. So we are working on that.
Thanks.
Stay tuned. Stay tuned.
Sure. Thanks.
Thank you, Sri. And I think if there are no other questions, let me just make sure on the chat window. Yeah, I think we don't have any other questions. Jim, thank you so much for talking to us.
Thank you.
All right. Quite welcome.
And thank you, everybody else, for joining in. We'll meet you all next week.
Thanks, Brian.
All right. Take care.